We're running a little bit over time, but I think this panel and the speakers, we have had such exceptional presentations that if you have questions, it is very clear to me sitting here as a surgeon that we're at a tipping point, I think, in gastric cancer early detection. It is clear that the unmet need is here and the science exists. And we just need to channel all of our efforts in the clinics, in advocacy, and in translational research to gastric cancer. So I'd like to see more gastric cancer in the funding announcements and gastric cancer at our national meetings. And so I'd like to open the floor up to questions. Does anyone have? I have a question, and maybe you guys can think of some questions in the meantime. For Dr. Corvalan, those patients who are waiting for the endoscopies, are there symptomatic patients? Are they people who've had positive findings? Who are the population that's waiting?
Usually, those are patients that goes to general practitioners, and based on the symptoms, they refer to endoscopy. So they have some kind of symptoms. And what happened that people in Chile in that specific area, they are aware about the risk of getting gastric cancer. So one of the facing issues that we found that is in some way there's kind of over-indication of endoscopy. So the waiting list is real, but in some way it's a kind of prevention. Not we don't have any strategy for primary prevention. So sometimes there's overdiagnosis of the indication of a waiting list of the endoscopy because people is aware about the risk, but most of them they have clear symptoms in terms of digestive problems.
Okay. Anyone else have any questions?
I have a question for Dr. Young. So you had mentioned the pancreas cancer detection network. So that seems to be jointly funded by NCI and NIDDK. How difficult is it to manage a multi-institutional network like that?
Actually, that's an interesting one because the NIDDK has a different thought on how they manage and actually set up funds. So the program came in with more of tell us what you have, tell us how you can collect samples, and then we'll talk about projects after you're funded. And where the NCI, you come in with specific aims and get reviewed on that, and then you work on those. So there was a good amount of cross considerations to be. But once it was up and running, it seems to be working very well. They meet twice a year, and a lot of they includes diabetes, it includes pancreatitis, it includes child diabetes. So a lot of it's really not focused on cancer, but there is definitely a crossover, and it's actually led to a collection for what they call new onset diabetes, where they're trying to collect 10,000 samples of patients that were recently diagnosed with diabetes, because that's a marker for pancreatic cancer.
Great talks, and excuse my naivety because I do not do research in the gastric cancer field, but I'm struck by the data showing the increased risk associated with gastric intestinal metaplasia. But then going back to look at biomarkers such as the Cologuard, are there any biomarkers in the stool that's different compared, looking at patients with different degrees of gastric intestinal metaplasia versus family history?
I don't know if there's any out there that's been looked at. Some of the concerns or some of the thought patterns with colon biomarkers, especially in the stool, is a false positive for colon might actually be a true positive for gastric or esophageal as it bleeds down or flows down into the colon. The stool samples would have the microbiome, which could clearly be an indicator of changes in the digestive system that may be caused by the effects of that, as well as the DNA markers may be sloughed off and coming down. So methylated vermentin is a marker that's being looked at for esophageal cancer, but it's often found in colon cancer, and it was going to be part of the Cologuard at the early stages, but they seem to have dropped that out. So yes, these are very likely that they may work. The FIT also, blood in the stool, it could be an indicator of gastric cancer. So they just have to be validated along the way.
Yeah. I actually wanted to ask one more question of Dr. Yeoh. You had mentioned that the biomarker grant studies submissions that come to you, there are no gastric cancer, and then perhaps that it's either a problem of no one submitting, which I don't think that's the case, or that they don't get through the reviewers, and you mentioned you may want to address that. If you had one advice to give to all of us who are submitting these grants for gastric cancer specific, what is it that we should be doing?
So the first advice that I give everybody is talk to your program officers.
Okay.
For any grant that you're going to submit, because we listen to the reviews as much as possible, so we can pick up on what the reviewers like and what they don't like. We can't tell you what they're saying, but it helps us to address what's bad and what's missing. So that's the biggest advice. The alternative way around it, if we can put together a funding a plan that would require a special emphasis panel, then we can actually recruit reviewers that have the expertise needed to study this. And then the third one is for the biomarkers groups, most of them are going to the cancer biomarker study section.
I see.
And so we can suggest reviewers to them to have put on their panel. So if any of you would like to be an expert reviewer in the cancer biomarker study section or know someone that would fit that bill, you can send me your name and we can send it along to the SRO, because they are always looking for new people to take on that responsibility.
Dr. Camargo, would you like to make a comment to close the session for us?
We actually have one more
Oh,
question
you have one
here
more
too.
question.
Hi, I have a question for Dr. Yeoh and Dr. Chan. For Dr. Yeoh, I wanted to know if you guys invite patients to be on the review panel. And for Dr. Chan, I wanted to know when your clinical trials will be open for patients to enroll.
So the study section review panels do not include patient advocates unless they have the criteria of a science background to understand the review. They're very confidential. They're very restrictive. We do bring in patient advocates to our EDRN meetings and many of our other consortium meetings. We also bring in the advocacy groups. PanCan and Barbara Kenner are big components of our two pancreatic cancer consortia. And PanCan has actually helped funding the new onset diabetes studies. So we do work with them, but the reviews, that's a real strict and closed session.
So our imaging trial is open already at MGH for Barrett's esophagus, pancreatic cancer, and colon cancer. And we're currently in the process of amending and getting approval for the gastric cancer component, and that would be open very shortly. And that's based at MGH. We're also hoping to open that study as well at Memorial Sloan Kettering. So we're in discussions right now with our partners there, and also there's a company that's providing us the imaging agent, so they are involved in trying to potentially get the imaging agent to Sloan Kettering. So that's the imaging-based stuff. Then with the liquid biopsy type markers, we're doing that within the context of the imaging studies, but also within a clinical trial of patients that have local regional gastric cancer that are undergoing radiation therapy and chemotherapy. And that trial is been formally approved, is currently being reviewed, and so that should be open, I would anticipate, by the summer. And that's also at MGH, and we'll hope to accrue about, I think the goal is to recruit 40 patients to that study.
Okay, great. Why don't we stop here? Let's take a 15-minute break. We'll resume at 10:30.